Hello and welcome to another episode of Think Development Out Loud. Today we have Dr Alessia Maccaro, who is a World Co-Fund Research Fellow with the IAS at the University of Warwick. Alessia has a PhD in Philosophical Sciences with focus on bioethics from the University of Naples Federico II. She is at Warwick responsible for the ethical aspects in the Applied Biomedical Signal Processing and Intelligent eHealth Lab at the School of Engineering, which is directed by Professor Leandro Pecchia. Welcome, Alessia.
Hi everyone, I'm Alessia. My research project is about medical devices in Africa, ethical aspect and universality of norms. I start from bioethics studies, then I moved my research to a much more application field, which is that of medical devices, or better, how the European regulation on medical device, which claim to be universal, can be applied in the particular context of the low and middle income countries, with particular regard to sub-Saharan West Africa. In continuity with my previous research, there is a reasoning between culture that I call particularism and rights, human rights, so-called universalism. Now my research starts from the consideration that science and also technology, in particular if it's related to healthcare, is a human right, so should be accessible to everyone. And this is reported by some of the major international declaration of rights documents. Is also the third sustainable development goals, the universal health coverage. But we can see that the spread of health technologies, in particular medical devices, is not universal. In fact, most of the world population does not benefit from the use of medical devices. Less than 15% of the global population accounts for the use of over 75% of the medical devices, suggesting an inequitable access to healthcare in favor of high resource settings. The issue is not only related to the access to the healthcare. Some other principles are involved, as the availability, the acceptance, the appropriateness, the affordability, the so-called 5A of the WHO. And all of those could impact on quality, safety, and effectiveness of technology for health. So we could easily understand that the other human rights are compromised. The one who declares the non-discrimination or the right to equality and so on. Most of the global population is treated in low middle income countries, but all medical devices are designed for high income countries like Europe, USA, Japan, which account for the 87 or 95% of global market. In addition, designers of medical devices take for granted basic Occidental infrastructure, while medical devices operational conditions in low and middle income countries' medical settings are deeply different. So we can deduce that of all European and American regulation on medical devices are not universal as they may seem. In fact, they do not consider that in some countries as low and middle, they could not be respected. The fact is that maybe consider this as provocatory, regulation on medical devices respond to some political and economical choices that are inspired to the libertarianism, the Adam Smith theory, the idea of free trade in the common market, bound to the idea of liberty, of the laissez-faire. This is so different from the liberalism of Locke related to the idea of freedom and to defense of human rights. And this brought to the definition of some standards, norms, which have economical reasons, the idea of the easily sell in the common market. That with the years has become to the competitiveness among rich countries and definition of minimum requirements and criteria impossible to be attended for low and middle income countries from itself, and that make the medical device designed in the high income countries impossible for a long-term survival in low and middle income countries. In fact, some norms or standards could not be attended in low and middle income countries. In effect, 93% of sub-Saharan countries do not have own regulation on medical devices and adopt, but in fact suffer the European ones. The consequence of that is that medical devices' effectiveness and safety is diminished, and for a part of the world, principles' rights are not guaranteed. About principles, I think that the compromise of most of all moves from the underestimation of one, the appropriateness, because too often is neglected to consider that medical devices should be designed and regulated, considering if they are appropriate to the context in which they will operate. In effect, we can say that the lack of consideration of the appropriateness, or we can say the particularism of each context, compromises the universalism of norms and standards. In effect, there are some subjective and also objective factors that should be taken into account. As objective ones, recognized also by WHO, most of low and middle income countries do not have their own regulations, regulatory authority for medical devices, qualified human resources, knowledge, budget availability, unreliable medical settings. And about subjective factors, I think that regulation should take into account the fact that different countries has different historical context, culture, traditions, perception of health and care, priorities, population, individual needs, ethics. But this does not mean to fall into a relativism that does not allow unitary perspectives. In fact, the exasperation of subjective and cultural factors could equally threaten the guarantee of human rights and principles. Universalism is correct only if do not assume only one perspective, the Occidental ones, the high-income countries one, and don't have economical or political reason point of view, but if considered that exists a lot of different perspectives and some principles arise that must be considered with priority than any other reasons. In fact, only widening the universality as assuming all the spectrum of principles, which means at the same time considering the particularity of each context, of different contexts with their subjective and objective factors, local aspect, is possible to arrive at a full citizenship of rights and social equality. My work is extremely interdisciplinary and also multi-methodological. The type of study I prefer is take the methodology from cultural anthropology, ethnology, political philosophy, insofar as it authorizes and guides all a very significant empirical research, indeed new for a philosopher. During this fellowship, I learned how to get out of the idea that a philosopher only needs theoretical research. I usually combine empirical research. I did 4 field studies in Africa, in sub-Saharan Africa, in Benin, and theoretical investigation, referring to the theory of Shaila Ben-Habib, Martha Nussbaum, Amartya Sen. Then I recur to multi-criteria decision analysis to identify, classify, and prioritize local, subjective, and objective factors. Or I use Delphi survey with experts, participation to forums of experts with scholars from Africa. I consider values and principles, ethical theories, specific philosophical point of view, which consider particularism of culture for my literature review. A big attention I gave to the field studies, I said before, I did 4 since now, during which I've organized the focus group, semi-structured interview, face-to-face interview, in order to capture subjective and objective local factors that should be taken into account. Now I work in the ABSPI lab, Applied Biomedical Signal Processing Intelligent eHealth Lab, multidiscipline lab directed by Professor Pecchia, working on medical devices design and regulation in collaboration with some of the most important scientific society, WHO, European Parliament, and I'm working on the definition of an hermeneutic, that means interpretative, and heuristic, so empirical framework for guiding biomedical engineers from Europe and Africa as designers in considering key gaps between low and middle income countries and high income countries affecting medical device safety and effectiveness. For example, make the design more resilient to sub-Saharan Africa working condition without affecting its costs. Or I refer also to writers of international regulation fostering the harmonization among across low middle income countries and high income countries. But the harmonization will be possible only if there will be a cooperation among African experts that should clarify their specific need, and European one, which should take into account local subjective and objective factors. I also will address to policymakers in defining more universal regulation that takes into account not the economic reason, but I also will address to policymakers in defining more universal regulation that takes into account not economic reasons, but the defense of human rights and dignity to increase the universality of norms and regulations. To conclude, bioethics is defined by its founder as a bridge to the future. The framework is important to allow communication even between scientists and politicians in the public debate, where if it's true that politicians must acquire more solid scientific culture, it is also true that men of science must acquire a more solid political culture and growing awareness of their social role. After all, the sense of bioethic, which is the discipline I'm dealing with, is actually keeping different knowledge together and bringing to the attention of the public debate issues that are usually considered only to be prerogative of experts. So we can find a new possibility of dialogue. Utopia is something necessary to overpass limits of our commitment forward.
Thank you, Dr. Alessia.